Hey folks, I'm here at Recess X with all y'all, and I often consider being able to take care of critically ill patients as a superpower. And hopefully we can go through some relevant recent literature and that can add to some of those superpowers, and you can take home some of this pivotal information to the bedside and help you care for these patients. And today we're actually going to go through the COD Trial, which came out a few months back. And here, investigators looked at hydrocortisone therapy for patients with community-acquired pneumonia who were severe and sick enough to be admitted to the ICU. Now, strap in and get ready while we explore the potential for this game-changing therapy and taking care of those folks with severe community-acquired pneumonia. Now, before we get in, let's just take care of a little bit of bookkeeping. I have no financial disclosures or conflicts of interest. I am a podcaster, author, and regular contributor to Rebel EM, and everything you're going to hear today came from a recent post in Rebel EM. And we'll supply the QR code at the end of the talk so y'all can take a look and review everything we've discussed here. And here's the paper. The authors concluded that among patients with severe community-acquired pneumonia being treated in the ICU, those who had received hydrocortisone therapy had a lower risk of death at 28 days compared to those who had received placebo. Let's break it down. So why are we giving this talk? What are our objectives here? Now, our goals are to critically appraise the findings of this trial. And we're going to decipher what exactly the COD trial means. And can we take some of this information back to the bedside as we spoke about, especially when it's time to make those critically important life-saving decisions for our sickest of the sick patients. Now, let's move on to the heart of the matter. Now, what exactly was the clinical question that they were asking? Why did they do this study? What they were saying is in adults who had severe community-acquired pneumonia, who were sick enough to be admitted to the ICU, does giving those folks hydrocortisone therapy improve mortality in 1 month, about 28 days, compared to placebo? Now, how did they do this trial? Now, again, this is a double-blind, randomized control, placebo-controlled trial, which was done at multiple centers in France. Double-blind randomized controlled trials are considered the gold standard to keeping results unbiased in medical literature. Now, as we said, this was done in France, and what they did was they randomized patients who met the inclusion criteria in a one-to-one fashion to receive an infusion of either hydrocortisone or placebo. And they actually assessed almost 6,000 patients, and they whittled it down. They were able to get 800 patients who met their inclusion criteria enrolled in the trial. Now, who were those patients who were eligible? Well, they actually included anybody who was above 18 years old, who they diagnosed with severe community-acquired pneumonia. Now, severe was based on specific clinical criteria which they predetermined. And those things included the need for mechanical ventilation, high-flow oxygen, and a number of other factors. What about exclusion criteria? Who exactly did they exclude? They actually excluded a laundry list. There's quite a few exclusion criteria. It seemingly is almost everyone. But what they were trying to do is to get to the patients or exclude those patients who would have either clearly benefited or clearly been harmed by hydrocortisone therapy. And for example, patients with COPD were excluded because those are patients who would have clearly improved had they been given corticosteroid therapy, and it would have muddied the interpretation of these findings of the paper. Now let's examine what the core interventions were. So the hydrocortisone group received hydrocortisone therapy, 200 milligrams of continuous infusion daily for 4 days. Now, there were specific improvement criteria, and they could extend that therapy from 8 days all the way to 14 days, depending on if the patients were improving or not, or how fast they were improving. And the control group received normal saline in the exact same manner. Let's talk about our primary outcomes. Our primary outcome was 28-day mortality, which is, again, a pivotal primary outcome in patients who are severely ill and in the ICU, and perhaps even in mechanical ventilation. Now, as far as our secondary outcomes, they weren't just looking at 28 days. They extended the survival rate all the way up to 90 days. And they looked at things like in those patients who were not on mechanical ventilation at the start of the study, what percentage of them had actually required mechanical ventilation. In patients who were not on vasopressor therapy at the start of the study, what percentage of them had required vasopressor therapy. They also looked at some safety outcomes, which we know can be caused by hydrocortisone therapy, like GI bleeding, infections, and insulin requirements. Now, again, as we mentioned, they assessed 6,000 patients, and with the exclusion criteria, they enrolled 800 patients, and that was about 400 patients in each arm of the study. And what they found was there a statistically significant difference in mortality in the primary outcome. And the hydrocortisone group experienced a 6.2% rate of mortality, but the placebo group actually had a much higher rate of 11.9%. What about our secondary outcomes? Now, the mortality at 90 days for the secondary outcome in the hydrocortisone group was 9%, while the mortality in the placebo group was a much higher 15%. Now, if we look at patients who are on mechanical ventilation, who are not on mechanical ventilation at the start of the study, patients in the hydrocortisone group needed mechanical ventilation as the study progressed only 18% of the time, while those in the placebo arm needed mechanical ventilation 30% of the time. If we look at those patients who were not on vasopressor therapy at the beginning of the study, in the hydrocortisone group, 15% of those patients went on to require vasopressor therapy, while in the placebo arm, 25% of those patients required vasopressor therapy. Let's move on to the strengths. So firstly, the investigators asked a clinically important research question, which has real-world significance. And they chose a gold standard research model, a double-blind, placebo-controlled, randomized controlled trial. And this has the potential to limit bias, also increases the reliability of our findings. This was multiple centers. They had 31 centers, and they assessed nearly 6,000 patients. And at 800 patients, it's the largest such trial looking at this specific research question. They also used a concealed, centralized web-based randomization process. So that ensures that there's no unmasking or unblinding of patients and that the randomization process can't be tampered with, or the chances of being tampered with are pretty small. They also assessed patients for eligibility in a consecutive manner, and that has the potential to limit some selection bias, although we'll get into limitations. There's a number of issues in there. And the researchers blinded the treating physicians, research personnel, patients, and outcome assessors to the actual treatment protocol, to whether or not the treatment allocation, I should say. And that limits the potential for bias as well. The medications and the infusions also were identical, and that limits the potential for unmasking, again, which could also introduce bias into the study. Next, as far as outcome assessment, the investigators labeled patients with missing data as having met the primary outcome, which is what you want. That increases the validity and increases the robustness of the information that you're getting. And lastly, as far as the strengths are concerned, they were looking for severely ill patients who were admitted to the ICU, and that's actually what they got. 45% of the patients enrolled in this study required some form of mechanical ventilation. So this was a pretty sick cohort, which is likely reflective of what we were seeing, these patients who were admitted to the ICU. Let's move on to our limitations. For one, this is a single country. This is just done in France. Now, do patients with severe community-acquired pneumonia in France, are they reflective of the entire population or the entire globe of patients with the same condition? Obviously not. The researchers also used really strict exclusion criteria. Now, although it was a consecutive sample, that introduces some selection bias in the patient population. They also expected a much higher mortality rate than they actually achieved. They expected a mortality rate of around 27% in the placebo group and around 20% in the hydrocortisone group. But what they got was actually much, much lower. So when they calculated the power, they calculated they needed a power of 1,200, but they stopped this study early for benefit at 800 patients. And that limits the robustness and the statistical power somewhat. Well, it's also important to mention that while 31 centers participated, 45% of the patients, or just under half of them, came from just 4 ICUs. And we don't really know much about these ICUs, but potentially maybe these ICUs were just much better at taking care of these types of patients and the other ones were smaller centers, but who knows? It does somewhat limit the generalizability to other institutions and to the broader healthcare system. It's also important to note that 70% of the patients enrolled were men, and the average in the median age was 67. This is likely reflective of what patients who have severe community-acquired pneumonia look like, but it does limit generalizability to both men and an older population. Let's take a moment to look at the baseline demographics. And baseline demographics were not quite the same, and there were some important differences. And for one, the patients in the placebo arm had a higher median PSI score, or pneumonia severity index score, of 130, while the patients in the hydrocortisone arm had a median pneumonia severity index score of 127. That may not seem significant, but that technically puts them in different groups. And those different groups, category 4 and 5, have vastly different mortality rates. We mentioned already, but the study was stopped early for benefit. And studies stopped early for benefit have the potential to overestimate results. And also, one of the things we don't really know much about is we don't know much, if anything, about what other medications they received outside the study. And this could lead to co-intervention bias. These were pretty sick patients who were admitted to the ICU. They likely got a number of other medications. And if there were big significant differences in the types and the quantity of medicines that they were getting, depending on what arm of the study they were in, that could potentially bias the results in favor of one therapy versus the other. Another important limitation is that they did not require a search for pathogens. They excluded anybody with influenza, but they did not require the care team to actually conduct a search for influenza. It was at the discretion of the care team. And they don't really mention how many patients were tested in each study arm. They do mention that there was no difference between the two arms as far as a diagnosis of influenza. We don't know how many patients were tested in each arm. And lastly, more than 3/4 of the patients in the entire group of both placebo and intervention arm did not finish the course of treatment. And it's unclear how this is going to affect the results. Now, corticosteroids likely have the potential benefit in patients with severe community-acquired pneumonia based on this paper and other similar papers. It's likely that corticosteroids only provide benefit in the sickest patients who require ICU and who don't have any contraindications. So this is a very specific population of patients. The magnitude of this benefit is also unclear, but it's probably not a huge number. This is not so dissimilar to other critical care trials showing a huge benefit with a single intervention in a heterogeneous group of patients who have a single disease process really hard. And whether or not a person survives likely depends on other contributing factors. The potential benefit for corticosteroids, it's likely there early in the inflammatory process. We saw in this trial compared to other trials, they instituted the hydrocortisone therapy early within the first 24 hours. And lastly, one of the things they found on subgroup analysis was that there seemed to be a trend towards benefit or favoring those patients with severe community-acquired pneumonia with markedly elevated CRPs, which were greater than 150 milligrams per liter. So it's possible that there may be a subgroup of patients who may confer more a benefit from hydrocortisone therapy, and it may not just be a one-size-fits-all approach. So let's take a look at the numbers. What we found was early hydrocortisone therapy significantly reduced 28-day mortality. As we said, the hydrocortisone group had a 6.2% mortality rate at 28 days versus 11.9% in the placebo group. This was a statistically significant benefit, and the investigators found that these benefits were consistent across secondary outcomes. This equates to a relative risk reduction of 47% and an absolute risk difference of 5.7%. That means that there is a 5.7% lower chance of dying at 28 days in the hydrocortisone group compared to placebo. And that translates to a number needed to treat of just about 18. That means for every 18 patients who have severe community-acquired pneumonia admitted to the ICU, one patient's life will be spared in 28 days if you give hydrocortisone therapy. But it's important to note that the fragility index of this paper is 6. And that means that the benefits or the results of this paper hinge on just a few events. So if just 6 patients change their outcome, that could flip this trial from a positive trial to a negative trial. Let's talk about bias. We already mentioned selection bias and outcome and assessors for eligibility. We have to explicitly state that 86% of patients who were screened were excluded from this trial. And while it makes sense to exclude patients who would have been clearly benefited by hydrocortisone therapy like COPD, some of the other exclusion criteria were somewhat subjective. For instance, 10% of the patients who were excluded had aspiration pneumonia. Now, when we think about that, aspiration pneumonia is often based on diagnosis and a classic X-ray pattern. So you need a patient who has a history of vomiting and then has that stereotypical X-ray finding, but this might not apply to every single patient with pneumonia. And there's a chance that some of these patients who did not have this typical story and typical X-ray pattern could have been missed. They also excluded 25% of patients based on a diagnosis of septic shock. Now, this is important because 45% of the patients were on mechanical ventilation. And we know that if you're on mechanical ventilation, you likely require some sedation. Both of these interventions can actually cause hypotensions, which may necessitate being on pressors. The discretion or the diagnosis of septic shock was based on the discretion of the treatment team. And we don't know if some of these patients who were mechanically ventilated on sepsis were actually just hypotensive because of side effects from their therapy. And also, as we mentioned earlier, influenza patients were excluded, and whether or not testing was needed was based on the discretion of the team, and they didn't give us any information at the number of patients who were tested. And as we said, there's a number of important baseline differences, and the biggest one is really the pneumonia severity index score. So patients in the hydrocortisone group were categorized with a PSI level 5 or category 5 pneumonia severity index 50% of the time versus 45% of the time in the placebo group. I'm sorry, that's reversed. The placebo group had a higher percentage of patients in category 5 PSI at 50% versus 45% in the hydrocortisone group. Now, category 5 pneumonia severity index group carries a mortality rate of 30%, while category 4 carries a mortality rate of 10%. So that means that patients in the placebo arm had a higher baseline predilection of death based on their pneumonia severity index score. Let's talk about current events. There was a recent study done in the US in similar patients, done at the VA actually. And this was 600 ICU admitted patients with severe community-acquired pneumonia. What they found was actually there was no benefit when they administered methylprednisolone, but they extended the treatment hour to 96 hours. There's a number of important differences between the two trials. And for one is that this VA study, nearly 100% of the patients, I think it was 96% of the patients were male compared to the Cape Cod study. And in Cape Cod, actually, on subgroup analysis, they found that there was some statistical signal, that women may benefit more from hydrocortisone than men. Again, the other important difference is the treatment timing. Cape Cod required treatment within 24 hours, while this VA trial allowed for treatment up to 96 hours. Now, if we move on, there was a recent meta-analysis which looked at 18 randomized controlled trials, and it was done this year. It was nearly 5,000 patients. What they found was corticosteroids, to a moderate certainty degree of evidence, are likely to reduce mortality in severe community-acquired pneumonia. They're also likely to lessen the need for mechanical ventilation and potentially lower the need for admission to the ICU. So it's likely that early administration of corticosteroids can reduce mortality in severe community-acquired pneumonia. And I want you all to take out your cameras and point them at this QR code. And this is a link to the Cape Cod trial, which has recently been published on Rebel EM. So go ahead, take a moment, review it for yourself, save it to your favorites, and refer to it at a later time. You all have a wonderful day and enjoy the education.